I wanted to start off with this cute cartoon. Doctor, I have a suspicious looking mole on my shoulder. As skin resource nurses, you're going to be asked to decipher various wounds or lesions and decipher whether they are pressure or not. And so that's what we'll review today. The learning objectives include discuss how to document assessment of wounds, identify stage 1, 2, 3, 4 unstageable pressure injuries and deep tissue pressure injuries, identify mucosal membrane pressure injuries, explain the etiology and clinical manifestation of pressure injuries, differentiate pressure from arterial, venous, diabetic, surgical, and trauma wounds, decipher between a bruise and a deep tissue injury, identify high-risk patients for skin breakdown, and initiate various strategies for pressure injury prevention. So I want to start off with the basics, skin facts. The average adult skin covers about 3,000 square inches. From birth to maturity, the skin undergoes a 7-fold expansion, weighs about 6 pounds, is the largest organ, and receives 1/3 of the body's circulating blood volume, and is capable of self-regeneration. So lost skin cells are replaced with new skin cells and repairs itself by connective tissue formation or by scar formation. So skin functions include protection. So the skin provides a barrier that's so effective that there's limited percutaneous drugs out there. So it protects against mechanical assaults due to the protective tough fibroelastic tissue of the dermis, collagen, and elastin. It protects against pathogens, chemical, aqueous, bacterial, and viral by the constant shedding of the dead skin cells by bathing, hand hygiene, scratching, exercising. It also protects against ultraviolet radiation from the skin pigmentation melanin. Also, provides skin immune system by the Langerhans cells that are antigen-presenting immune cells that protect against microorganisms. And also by thermal regulation, by vasodilation and vasoconstriction. Vasoconstriction by creating the hair follicles to stand straight up, creating what we call shivering or goosebumps. Sensation protects against pain, temperature, and pressure, as well as metabolism. The skin provides synthesis of vitamin D for the body as well. And then, of course, communication, such as facial expressions to communicate, pouting, smiling, and frowning. So we're going to also go over terminology to help increase your documentation skills regarding wound care. So with exudate consists of the fluid and leukocytes that move from the circulation to the injury site. So this is a migration of the white blood cells to the site for phagocytosis to digest bacteria and break down the necrotic tissue. So when you're documenting exudate, you want to document the nature and the quantity of the exudate, and that depends on the type and severity of the tissue involvement from the injury. So types of inflammatory exudates. Serous, that's a clear, thin, watery plasma that results from outpouring of fluid. So this can be seen in the early stages of inflammation. Examples, skin blisters, the serous blisters, or you see them in pleural effusions. Sanguinous exudate is the fresh bleeding. A small amount may be normal during the inflammatory phase, but if you do see blood in a wound bed, you want to make sure you investigate, is it due to friction or any type of trauma? Make sure you look into that. Maybe you have to apply pressure. Serous sanguinous, it consists of red blood cells and serous drainage. This is the thin, semi-clear, pink to red in color drainage. So you see this in surgical drainage fluid and incision sites or in your wound vac canisters. You will see this type of drainage a lot of the time. Fibrinous drainage occurs with increased vascular permeability and fibrinogen leakage into the interstitial spaces. So fibrinous is the adhesions or those gelatinous fibers, ribbons that you see in JP tubing. That's why it's so important to strip the tubing so it does not clog the tubing. You also see fibrinous in venous ulcers and lower extremities as well. Hemorrhagic results from the rupture of or necrosis of blood vessel walls. So the examples, hematoma or bleeding after surgery or trauma. And you may have to apply pressure or call the surgeon if you can't control it. Purulent pus and consists of white blood cells, dead or alive microorganisms. So this appears opaque, thick, tan, green, yellow, drainage. It's not normal, of course. You suspect infection and notify the doctor. Examples, abscess, cellulitis. Catarrh is found in tissues that produce mucus, and mucus production is accelerated by the inflammatory response. So a runny nose due to upper respiratory infection. More terminology. So these are a lot of terms that describe dead tissue. So necrosis is death of tissue, black, brown, yellow, green tissue. Ischemia is the lack of blood supply leading to cellular damage, and if not alleviated, can cause tissue necrosis with your pressure wounds. Devitalized tissue, also known as non-viable or dead tissue. Eschar is that black, brown, or gray necrotic devitalized tissue. This may be firmly adherent to a wound bed surface or retracting from the wound edges. Gangrene, this is necrosis due to poor blood supply. This can be local or an entire extremity or organ. Slough is necrotic tissue as well. This is a lot of times when you see that yellow tissue that's loose or stringy or firm adherent to the wound bed. Erythema is redness of the skin. This can indicate injury, inflammation, or infection. But redness can be a normal sign or a normal inflammatory response that you get from injury, and it can last up to 1 to 4 days due to the vasodilation. Blanching is a temporary whitening of the skin after pressure applied. And non-blanchable erythema is the redness that persists after pressure is applied, and that's due to poor blood supply. All right, more terminology. So when you're talking about a wound bed or base of the wound bed, that's the visible tissue of the wound bed that you're describing. A clean wound, when you say it's a clean wound, this is free of necrotic tissue, free of devitalized tissue, purulent drainage, as well as any foreign material debris. Peri-wound is when you're describing the surrounding skin of a wound. Induration is the abnormal hardening of the tissue, and this is caused by congestion, edema, or inflammation. And many times it can be a sign of infection, so that's why it's really important to palpate around the wound as well. Now, lesion is a term, it's a general term to describe any change in the tissue regarding injury or trauma. A lot of times I don't use it a whole lot, but maybe for a wound, a sore that I'm unsure what the cause is, you can simply say lesion. Maceration is prolonged exposure to moisture. The skin appears white, so when you're in a pool too long, you get the pruny, wrinkly fingers, and it turns white. That's maceration. Abrasion is this is loss of the epidermis or upper dermis removed due to external force. So example, friction, or you skid your knee. That's simply abrasion. Dehiscence. This is separation of a surgically created incision. This can be due to infection, malnutrition, or tension on the suture line. Denuded. This is loss of epidermal layer of the skin. A lot of times I see this around the perirectal skin related to moisture and incontinence. Ecchymosis, bruising, discoloration of the skin. Black, blue, purple in colors caused by the infiltration of the blood from blood vessels into the surrounding tissues. Excoriation, this is disruption of the epidermis or dermis from scratching, from abrasions, chemicals, or any thermal damage. Fistula is an abnormal opening communicating from organ to organ or organ to skin. So example, enterocutaneous fistula. Entero meaning bowel, cutaneous meaning skin. Hemosiderin is that brown pigmentation that is seen in patients with venous hypertension. So the hemosiderin staining has the red blood cells carrying the iron-containing pigment that can leak into the tissues. And that breaks down, leaving the hemosiderin in the lower extremities that you see that brown pigmentation in venous insufficiency. Hypergranulation. Granulation tissue that is raised above the wound surface. So this is related to maybe too much moisture. And what we call this a lot of times is proud flesh, where the granulation tissue is raised above the surface level. So a lot of times I have to get that moisture controlled in order for those epithelial cells to glide across the wound. They can't migrate upwards, so you have to get the moisture controlled, get it to surface level in order to close the wound. All right, assessment. It's very, very important to do a very thorough head-to-toe skin assessment and identify any wounds and document. Make sure, for example, there's been cases where it was not thorough and just simply looking between the gluteal folds. They've been, an ulcer has been missed between the gluteal folds, and then the facilities have had to acquire it because it was missed on admission. So make sure you are doing a thorough assessment. You want to observe and document wound characteristics. You want to document the location on the body, this category or stage of the pressure injury, which we'll go over, the size. You want to measure the wound, the tissue type, the color of the wound bed, the peri-wound, the surrounding skin. Is it warm, cool? Is there induration? Is there breakdown? Ask if they have pain. Are the wound edges, are they macerated? Are they rolled over? Is there undermining or tunneling? Also, is there any drainage or exudate? You want to document the consistency, the color, or odor. For example, thick yellow drainage, foul odor, which may indicate infection, or small amount of serous sanguineous drainage, no odor. You also want to identify areas of scar tissue as well on the sacrum or heels, for example, because this can indicate an area, it's a weak area now. You only gain about 80% of your tensile strength once that heals. So you do want to identify those areas and maybe protect those areas of scar tissue as well, because they will be at risk for breaking down. And also document whether they have edema to an area as well, because they're going to be at risk for breaking down as well. I do want to go over location, because I do see this misrepresented a lot of the time on location. So the sacrum, just remember that's the base of the spine, and then the red area there is the coccyx or tailbone. So make sure you're documenting location correctly, as well as the ischium, the sitting bones. And that a lot of times wheelchair-bound patients, you'll find ulcers right on the ischium. So make sure you're documenting right, left, proximal, distal in order to decipher which wound when you're watching the progression of healing, and for CMS as well. Make sure you're precise on the location when you're documenting about a wound. Yeah, use medial, lateral, proximal, distal. All right, wound classification, identification. It's crucial to know the etiology of the wound. Look into the patient's history, whether it's pressure or not, or what kind of wound it is. Talk to the patient or families. For example, a patient may have purple discoloration to their right, it's falling apart, to their right hip, to their right thigh, may have purple discoloration. Someone may want to call it a deep tissue injury, but if you investigate, they had a horrific fall, and it was more trauma related rather than a deep tissue injury. So make sure you look into that. It would be more of a bruise related to trauma. Also, I've had cases where a patient had a wound on the sacrum, very, very deep, and everyone wanted to stage it as stage 4 pressure injury. However, if you look into the chart or talk to the family, they actually had a cyst removed that was causing problems. So it was more of a surgical wound rather than was not pressure. So make sure you know the history and you investigate a little bit further before, especially before declaring it pressure. Okay, so different types of wounds. There's surgical or there's non-surgical, arterial, venous, diabetic, neuropathic, or trauma wounds. So we'll kind of go into each one of those. So arterial is an ulcer that is caused from inadequate blood supply, arterial blood supply. So this is getting the blood from the heart pumped to the lower extremities. These ulcers are most commonly found on the distal lower extremities, usually on the lateral aspect of their feet or toes. Venous ulcers these ulcers result from venous hypertension. They're typically on the lower extremities, the lateral aspects of their legs. And this is related to the valves weakening over time, and that blood supply is not able to be pumped back up to the heart adequately, and that's where you get the weeping of the red blood cells into the surrounding tissue, and they're very edematous, and that's where you get that brown pigmentation in their lower extremity due to the weakening of the valves. Diabetic foot ulcer. So this is an ulcer of a diabetic patient. About 60 to 70% is associated with loss of protective sensation caused by pathology commonly associated with the disease, such as peripheral neuropathy. So you do want to look at their history, whether they're diabetic or not. Maybe they had improperly fitted shoes that caused an ulcer. So this is, once again, investigate, talk with the patient. A lot of times it's on the plantar surface of the foot, and they have callus formation, and we'll look into some pictures here in a bit too. Neuropathic ulcers are similar to diabetic. This is due to impaired function of peripheral, sensory, motor, autonomic nervous system deficits, so they have abnormal healing, decreased sensation, bone deformities, and loss of perspiration. So example, a patient that's on chemo for, been on chemo for long term, and they develop the peripheral neuropathy. They can also develop ulcers on their lower extremities or their feet. Traumatic wounds are abrupt, acute tissue damage resulting from physical, chemical, mechanical, electrical, or external trauma. So example, skin tear or a burn. This is separation from the epidermis from the dermis. Chronic wounds are those that do not heal within a normal time frame, approximately 3 months. There's also terminology, partial and full thickness skin loss. Partial thickness loss is epidermal skin loss and possibly dermal tissue loss, but not below the dermis. And then when you're describing a wound as full thickness tissue loss, this is epidermal loss and dermis loss that extends into the subcutaneous tissue or maybe even to muscle, fascia, or bone. You can also classify the base of the wound based on the color. So is it red, yellow, or black? Yellow or black is going to indicate to someone reading the assessment that there's necrotic tissue. And all the colors can be present in the wound as well. So when you're describing a red wound, you're describing healthy granulation tissue. And the purpose of the treatment is to prevent contamination. You want to prevent infection. You also want a moist wound environment for optimal wound healing and epithelialization. So the reason why you want moist wound healing, especially with this picture, you want those epithelial cells to migrate across the wound bed to close it. If it dries out too much, then those epithelial cells cannot glide across to close. And these can be superficial or deep. And okay, never mind, I'll talk about that later. Yellow wound bed. Yellow wounds are also known as slough, which is necrotic tissue. Non-viable necrotic tissue creates an environment for bacterial growth, so you do want to remove this devitalized tissue to accelerate healing. So example, mechanical debridement with dressing changes. So a lot of times you hear the wet to dry dressing in order to remove the dead tissue. They do want you to get away from that terminology, wet to dry, and more say wet to moist or a moist dressing change. Reason being is that there's been research that when you remove the dry dressing, it creates pain for the patient. It can actually damage healthy granulation tissue, cause bleeding. So they do want you to get away from that wet to dry terminology. There's also enzymatic debridement, which we will also talk about the different types of debridement. So there's enzymatic debriders that can also remove devitalized tissue as well. So these can be superficial or deep, or you can have pink red granulation tissue combined with the yellow slough as well. So in this picture, there is tendon exposed. So I may say 60% red when I'm talking about percentages on a wound, 60% red, 10% tendon, 30% yellow. However, if you don't know there's tendon, it's completely fine to document color. So you can say 60% red, 40% yellow. That is fine. So a black wound bed. also known as eschar, which is necrotic tissue in this picture. And this may require debridement, but stable, dry, hard eschar on the heels, you do not want to remove. This is the body's natural Band-Aid to prevent infection or bacterial from entering. So these heal from the inside out. You do want to palpate, though, and make sure that they're hard, stable, and make sure they're not soft, mushy, or gangrene, and that might need immediate debridement. So you can, if you do have drainage or if there's erythema or purulent drainage, that's when you would need to, it would indicate infection and need debridement. So how do you measure pressure injuries or other various wounds? You want to measure length times width times depth. You want to measure in centimeters. And you want to measure the length, which is the longest length. So that's head to toe, or 12 and 6 o'clock. Use clock positions to measure. Width is perpendicular to the length. That's 3 and 9 o'clock. You want to measure the longest width of a wound. The depth, you want to measure the deepest area of the wound bed. So you want to get a cotton tip applicator and find the deepest part of the wound bed and measure that to the surface of the wound. We're going to talk about tunneling and undermining. So tunneling, or a sinus tract, is a narrow pathway beneath the edge of the wound bed. And it extends from the wound edge under intact skin into one direction of dead space. So you do want to make sure with tunneling that you're packing them appropriately. You do want to know how far that tunnel extends to avoid abscess formation. So make sure you're educating your other coworkers as well regarding packing tunneling. The best way I describe it with my hands, but if you had a tunnel and you stop short of packing, it would close off, and that's how you get abscess formations. You get a pocket of fluid where bacteria like to thrive. So make sure you know how far back you're tunneling before you place the dressing. Undermining, this is tissue destruction underneath the peri-wound intact skin. This involves a wider range from the wound edges of open space. So we'll look into this a little bit closer. So clock position. So on this one, this is on a sacrum, and at 6 o'clock would be the coccyx area. So length would be from 12 to 6 o'clock, and the width would be 9 to 3 o'clock would be the longest length and width. Now with tunneling, you would see 8 o'clock, and you would measure that with a cotton tip applicator, and let's say 5 centimeters. And then undermining, and you would be probing gently to see where undermining and tunneling was at. And then undermining from 11 to 1 o'clock and 3 centimeters. Any questions with that? Clinical manifestations of inflammation. So there's a local response to inflammation. Redness is caused from the vasodilation. Heat is caused by the increased metabolism at the inflammatory site. Pain is due to the change in pH, nerve stimulation by chemicals like histamines, prostaglandins, and pressure from fluid exudates. That's a lot of times why they have pain. Swelling from the fluid shift to interstitial spaces, fluid exudate accumulation, and loss of function can be caused from the swelling and pain. So a systemic response to inflammation, you have the leukocytosis, the increased white blood cell count, malaise, nausea, anorexia, increased pulse and respiratory rate, and fever, indicating sepsis. You also want to look at diagnostic lab work and indicate whether a patient can break down or be at risk for poor wound healing. So you can look at a CBC, look at the white blood cell count, can indicate infection. A low hemoglobin can contribute to poor healing due to the poor inadequate oxygen blood supply. So a wound bed can appear pale. Sedimentation rate detects inflammation. C-reactive protein can detect inflammation, and increased levels can indicate infection. Low albumin less than 3 indicates malnutrition. And a total lymphocyte count less than 1,800 can indicate malnutrition as well. But you do want to look at the overall picture of the patient too. Just look at them. Are they thin, frail, bony? They could be at risk for breaking down. Maybe not just look at the wound all the time.